Welcome everyone. Today we are managing a closed displaced both bone forearm fracture in adult female of age 28 years with intact distal neurovascular status. On the initial X-ray, we see a mid to distal shaft fracture of both radius and ulna. Here our goal is anatomical reduction and absolute stability, which is essential for preserving the rotational mechanics of the forearm. We begin with the Bollard-Henry approach. After sterile draping and positioning the arm on the hand table, I mark the landmarks, the biceps tendon proximally and FCR tendon distally. In standard way, sterile scale is used. Here I use a cautery wire stretched between the two landmarks that helps to make a precise longitudinal incision line over the fracture site. Following the marking, skin and subcutaneous tissue is incised, maintaining the meticulous hemostasis. Skin flap is raised in both sides, where you can see a glistening white FCR tendon now. The superficial fascia is incised along the FCR tendon, then FCR is retracted ulnarly. We then perform a sharp stab incision of the deep fascia using myoscissors to enter the interval between brachioradialis, which is innervated by radial nerve, and a flexor carpi radialis, which is innervated by median nerve. continuing dissection between FCR and brachioradialis that will allow us to reach radial shaft. Using a periosteal elevator, we prepare the bone surface proximally as well as distally, ensuring minimal soft tissue stripping to preserve the blood supply, as well as preparing the surface of bone for plate placement. After thorough wash, we hold proximal and distal fragment using Allis forceps to achieve reduction. Instead of Allis forceps, bone holding forceps can be used, whichever you are comfortable with. For the radius, we are using 6-hole 3.5 mm dynamic compression plate. It is vital to center the plate on the bone longitudinally, as well as centering the fracture, providing 3-hole for proximal fragment and 3-hole for distal fragment. We apply the plate using compression principle. The first screw is placed in a neutral position on the distal fragment after standard drilling and depth measurement. To achieve the axial compression across the fracture line, the second screw on the proximal fragment is drilled in an eccentric fashion. Once the initial compression is achieved, the remaining screws are inserted to complete the construct, ensuring at least 6 cortices for proximal fragment and 6 cortices fixation for the distal fragment. Next, we move to the ulnar side. The forearm is held upright with the elbow in 90 degree of flexion. We make a longitudinal incision along the palpable subcutaneous border of the ulna. Here the approach is relatively safe as we do not encounter any major nerves. The incision is carried directly to the bone. The periosteum is elevated to expose the fracture fragment. In this case, the fracture pattern is sufficiently oblique to make it ideal candidate for interfragmentary lag screw. After irrigation, the ulnar reduction is maintained with using Ellis forceps. Similarly, we did in radius. We first place a 2.7 mm lag screw. In the lag screw technique, we have to drill perpendicular to the fracture to maximize the compression force. To protect the lag screw, we apply 7-hole neutralization plate. The fourth hole is centered over the fracture site. After fixing the plate, we alternately drill over the proximal and distal fragment until all the 6 screws are secured, providing stable construct. The surgical site is thoroughly irrigated with normal saline. To minimize the risk of surgical site infection, I prefer using Vancomycin powder, which is applied directly over the hardware. For closure, I prefer a direct subcutaneous closure. By avoiding a tight facial closure, we significantly reduce the risk of post-operative compartment syndrome. And later, the skin is closed in the standard fashion. This is our post-operative film. We have achieved anatomical alignment. The lag screw on the ulna is well compressed, and the plate on bone provides absolute stability. This will allow the patient for early range of motion exercise, which is key for preventing stiffness as well as early rehabilitation. Thank you for watching. See you in next video.